Hello dear endoscopist. Today I'm going to share with you a case of peroral endoscopic myotomy or POEM done with high precision and long selective myotomy within only 15 minutes. I am also going to share with you some tips, so please stay tuned. I am Muhammad Abdul Hafiz and this is the Endoscopist. So welcome back. So let's start our case. This is a patient history who was a 17-year-old male patient presented with severe regurgitation for 1 year associated with dysphagia to both solids and liquids. His ECHO score was 10 with dysphagia, regurgitation, chest pain, and some weight loss. Investigations done, endoscopy showed normal mucosa with some spasm at the level of the cardia. Barium swallow showed delayed esophageal emptying with classic bird's beak appearance. High resolution manometry showed elevated IRP, absence of peristalsis, panesophageal pressurization, and the diagnosis was type 2 achalasia. Here we can see the images of the manometry. As you can see here, we have here high IRP and failure of peristalsis or absence of peristalsis in the whole esophagus with panesophageal pressurization. So this is clear diagnosis of type 2 achalasia. And we decided, after discussing it with the patient's parents, we decided to go for peroral endoscopic myotomy as the best treatment option. So let's see now the endoscopy. We started here with diagnostic endoscopy. As you can see, there is foam, and always in any upper endoscopy, when you see foam and bubbles in the esophagus and the tubular esophagus, you have always to suspect esophageal motility. As you can see, we have spasm at the cardia, and we can also see some tertiary contractions within the esophagus. After we took our measurements, we start with the injection of normal saline mixed with some methylene blue. Give here a generous amount of injection, at least 4 to 5 milliliter. Try to be parallel to the mucosa, not to injure the muscularis propria at this point, not to do any perforation. So go parallel and then start very gradually to inject. The cardia here was at about 45 centimeters, so I decided to start my incision at 30 centimeter. After the injection, after having good lift, we do the mucosal cut. Very important to go deep with the first cut in the submucosa to make sure that you cut already the muscularis mucosa, which will fasten and help you to enter the tunnel very quickly. After I did about 1 to 1.5 centimeter mucosal cut, usually I keep it small so I can close it easily, I go with my cap, which is a conal cap from Fuji. I go with the cap, do some pressure on the edges, and I give some spray coagulation just to dissect the submucosa and loosen it up a little bit, which will help me to enter the space of the submucosa easily. As you can see here, we are already entering the tunnel in less than a minute. So only the edges, and with very minimal spray coagulation, we do the dissection. Again, I inject with the knife. This is a triangular knife from Olympus, which I love it when I do a POEM because its triangular tip has a very nice spray coagulation effect. After I enter the tunnel, I keep myself very near to the muscle layer, and I use the cap to do physical traction or pressure on the submucosa, which will allow me to open the tunnel, something like severe dilatation of the strictures. And this will allow me to do dissection of the submucosa with minimal current, with minimal electricity, and save time, and use minimal electricity, which will diminish as well the mediastinitis, which will happen after the POEM. Again, I'm keeping myself near to the muscle layer. You can see here the muscle fibers. Sometimes you can injure the muscle fibers during this process, but it's not a problem because we will cut it open at the end anyway. But the very important thing is to keep the mucosa intact during the whole process, not to have a perforation, of course, at the end. So again, keep yourself near as you can to the muscle layer. And I always keep the tip of my knife under visualization near to the scope to minimize any traumas or any injury that can happen either to the mucosa or to any vessel. And as you can see here, I give spray coagulation, very short spikes. Again, with the traction of the cap, it will open very fast. So again, regarding the measurements, the cardia was at 45 centimeters. So I want to do about 12 to 14 centimeter myotomy. At least 10 to 12 centimeter will be above the cardia. That's why I started the incision at 30 centimeter. I will start the myotomy at 33, 35 centimeters, and I will prolong the myotomy about 2 centimeters below the cardia. Again, as you can see here, we cut very smoothly. I keep my tunnel small. I just do the tunneling that I need to pass with the scope. I'm not a big fan of huge tunnels. Again, it is a collaboration between mechanical tunneling and minimal spray coagulation. I believe myself that smaller the tunnel, it will heal faster. And again, it is less coagulation, less mediastinitis, less possibility to hit a vessel or something. When we face any vessel like this, we'll just inject, and with the spray coagulation, usually we'll be able to coagulate the vessel without any bleeding. So I push, I penetrate the submucosa, I inject whenever it is needed. We are approaching here the cardia, as you can see. Here still we have a couple of vessels. Whenever it is possible for me to leave the vessels intact, I just leave them. If they are on my way and I have to cut through them, I just cut through them. But again, as a rule of thumb for me, I will leave the vessels whenever I can. At some points, I will feel I'm struggling with the tunnel because it's too small, so I will withdraw my scope a little bit, and I will just do some trimming at the edges, which will open the tunnel again for me, and I can pass further. Whenever you are approaching the cardia, you will start to feel that the space is becoming tighter for you. And here it is very, very beneficial to use the mechanical traction, because mechanical traction is much, for me, for my point, is much less hazardous than the electricity or the current. But of course, you have to do it very gently. And we are starting to see the sling fibers. There are some studies suggest to spare the sling muscle fibers to decrease the incidence of reflux and the severity of reflux after the POEM technique. I believe you don't have to do it, but if you can spare the sling fibers, of course, you go for that. And one of the main landmarks for the sling muscle fibers will be the two penetrating vessels, which you find immediately at the level of the cardia. When you reach the sling fiber, they are above each other with about 1 to 2 centimeters distance. We can see here, we see the first penetrating vessel. Once you see the penetrating vessel, you go to the right of this. Of course, I'm doing posterior myotomy, so I go to the right to the penetrating vessels. Again, my own belief that you don't have to do it, even in the studies, some data will show that it is beneficial to leave the sling fibers intact, and some will show that there is no big difference. As you can see here, I'm trying to open the space right to the two penetrating vessels. Of course, it will consume more time if you will do this approach. Here, it took about 2 minutes or 3 minutes extra to the procedure, but it is not a big deal. And I'm trying to be very cautious not to injure these penetrating vessels, because when they bleed, it's usually strong bleeding. and I push my scope again with mechanical force to open the third space here, or the submucosa. Now I have seen with my scope the second penetrating vessel, which is also a good landmark for your limit for the myotomy. So when you reach the second penetrating vessel, this is usually you are deep enough for your myotomy. As you can see here, we have to the right the circular muscles, to the left of the penetrating vessels we have the sling muscle fibers, which has some, again theoretically has some protective effect against the reflux. After we finished our tunnel, I was just inspecting that everything is okay. Then I will go out from the tunnel, then I will go again, and I will start my myotomy at about 3 to 5 centimeters below our opening, to have like 3 to 5 centimeter intact muscle and mucosa, which will help to seal the tunnel after that. I start with minimal coagulation on the circular muscle because my aim is always to do selective myotomy. So I do with the spray coagulation, some coagulation of the circular muscle till I have exposure of the longitudinal muscle. Now I start to see the longitudinal muscle, which is a different layer from the circular muscle. Then I will expose it more. Once I see this very clear and nice view of the longitudinal muscle and the circular muscle, that allows me to go for highly selective myotomy, very precise, and also in short time. I will push my scope. I will anchor with the tip of my knife in the layer of the circular muscle, and with very gentle spray coagulation I will cut it. As you can see here, I only used cut mode during the mucosal cut, and then I continued the whole process, either the tunneling or the myotomy, with the spray coagulation. So I go slowly, very slowly, cutting millimeter wise from the muscle layer. Again, I try to keep it as much as I can highly selective. Of course, sometimes you will hit the longitudinal muscles, or they are very weak. Usually they will separate from each other, and you will see the mediastinum. But again, I try to make it as a target for me to keep it closed. As you can see here at this area, the longitudinal fibers separated from each other, but this is not a problem. So this is again the area just above the cardia. So it's a tight space. So what I do here is I go out with the tip of the knife and I give spray coagulation again with non-contact, and the fibers will separate from each other. I will have a very nice and precise myotomy at this area with minimal coagulation. Again, I'm using the cap to put pressure or traction on the muscle fiber, so that will allow for a very nice and smooth separation when I give current. Watching, of course, the penetrating vessel, because I don't want to hit it with my knife. Cutting here again, and any circular muscle fiber I see, I will just cut. So again, as you can see here, the whole point procedure is a collaboration between mechanical dissection, traction, and the electrosurgical current. So we are going down, reaching our limit right now, with to the left from us at the second penetrating vessel. Now I remove the cap. I will have a look at the penetrating vessels, go back, making sure that there is no circular muscle fibers anymore. Making sure again that the whole mucosa is intact. I will have a look at the cardia and inversion. As you can see it here, it is resembling a small incompetent cardia, which is a good sign. Now the closure is very important. Usually I will put the first clip just below my mucosal opening. I use very small clips, 11 millimeter. When I put the first clip, it will make a fold, so it will fold the opening, approximating the two edges together, which will help me to do a very tight closure after that. Here's the second clip. And I pull, or I push downwards, then I close the clip, and it will grasp the two edges. I keep small distance between the clips to achieve a very tight closure every time. And here again, another advantage of having a small opening, small and clean opening at the beginning of the poem is the fast and safe closure and tight closure after the procedure. Usually it will take you something between 4 to 6 clips to close poem opening. Of course, there is some cases which is very, when you have severe fibrosis or something like this, you might use bigger clips or suturing or anything else. But in normal achalasia case, normal small clips will do the closure. And here we put our last clip. After the last clip, I go one time to the right from my clips to make sure that all the clips are grasping normal mucosa, and again to the left of this clips to make sure that also they are grasping normal mucosa, and the procedure is finished. The patient after the procedure, I kept him NPO for 24 hours. He was only allowed to have sips of water. On the second day, he started clear fluids for 2 days and then slowly resumed soft diet, then normal diet. No pain after the procedure, everything was fine, and he went home on the second day. So this was an example how POEM can be very effective, minimally invasive, with less complications and also procedure time. Thank you for watching. If you have any comments or questions, please put them in the comments below, and see you in the next video. Ciao.